The key is early diagnosis. Most of the cancers can be treated if they're diagnosed early enough.
Wel, y dwedais i yn fach o'r hun, fi si ffodus iawn 6 wythnos fi si gyd. Ond o'r rhai ohonyn teimlo bod o'r rhy hir deud y gwir.
There's also the issue of awareness of this disease, and it takes such a long time from presenting to the primary care. From that time to diagnosis is far too long.
I did feel that I did keep presenting the symptoms over and over and over again, and I wasn't being listened to. I have a key worker in the shape of the specialist nurse, and her job is to receive my call on a whim. I can call her anytime I like and she will address my problem. And of course her other patients.
Y prif neges ydy bod cleifion yn cael gwybod pwy ydy, dylen nhw gael beth mae'n alw yn Saesneg, y term Saesneg, key worker, pwy sy'n gyfrifol at pwy fedra nhw fynd mor sydyn a phosib felly.
The important thing for us is to have parity with the general cancers, whereby they have a key worker, and sadly we haven't been allocated a key worker. None of us have, and indeed that is a drawback within the cancer plan.
Swn i'n dweud bod angen gofal seicolegol deud y gwir i'r glaf. Na'n ffodus, dydy hynny ddim yn digwydd. O ddim yn aml iawn beth bynnag dio. Ac bod y claf yn cael rhywun i ateb i bryderon.
The awareness, I think, is down to, obviously you're going to have to keep checking your body, and I feel it's good because other people learn from other people's experiences. I feel that there should be more advertisement on television, because they put adverts on for everything else cosmetic, but there's not enough awareness for, especially even for young generation, to be checking their body for growths.
But they don't tell young girls to test themselves, test their breasts or whatever for any lumps or any signs of cancer.
I think lack of communication, which is down from hospitals to your local doctors to your auxiliary nurses. I think they all need to be working together as a team and to make sure that everybody knows what is going on, not just the consultants who actually do the operation.
Dwi'n ffodus o dweud hefyd bod fy meddyg teulu nawr, bob tro dwi'n gweld yr arbenigwr, mae o'n cael copi o'r canlyniadau a'r profion gwaed, ac dwi'n a fy hun yn cael bresennol gael hefyd. Felly mae yna fwy o draws doriad o help. Mae pawb yn gwybod beth sy'n digwydd, dwi'n meddwl, mwy rwan.
If we're going to genuinely be patient-centred, and we absolutely must be, then we've got to think what works best for the patients, not primary care, secondary care, this health board, that health board. We've got to streamline things and adopt best practice so that the patient, wherever they may be, whatever their health board, whether they come to the GP or whether they come into A&E, are going to get the best possible approach.
Someone needs to take ownership of what happens to an individual patient. And that is particularly important where, as has been mentioned already, if it's someone living in Milford Haven but they're coming to Velindre, for that patient can't fall between the cracks in terms of the way in which their care and the speed at which their care is delivered.
Key worker is key. In some of the specialities we have many and it's great, in others we don't. And that is very, very difficult for those patients going through. So it has to be a priority to make sure you never feel lost if you have cancer. You never feel as though you don't know what's going on, and you're always clear about where you are, whether things are good or bad, and that goes on into survivorship very much. So it is key, and it is patchy in areas against the more complex cancers, the rarer cancers, and it's very, very difficult to quantify what a CNS does.
The key worker role, though, has evolved sort of by stealth. I think it's never sort of wasn't a deliberately planned like let's make a bunch of people called CNSs who can do this. So they tended to be senior nurses who've just taken on a sort of extra role. And what we've realised is a bit like multidisciplinary teams. We suddenly realise we've got a bunch of people who do something that is really critically important.
Essentially what we're seeing is, and this is kind of a UK-wide issue, is that we are diagnosing later. So we are diagnosing a later stage in disease. If you unpick that a little bit, some of the qualitative evidence is showing that that's due to a number of reasons. There's definitely something about GP's ability to then access diagnostic tests. So we know that about a quarter of patients are actually diagnosed through emergency routes, which is suggesting that for whatever reason, diagnosis is not being made through the GP route.
But for things like neuroendocrine disease and those regional services, there is no structure at the moment for cross-health board planning, and it does drive you to tears to know that the money has to follow the patient in the end. We haven't got a system for that to occur. Neuroendocrine, it would be much better for a very specialist service in Cardiff to offer that advice, but patients then managed locally. But you try getting money to follow patients and it just doesn't happen. And in the end, we're going to, the model at the moment is to break up that service.
Patient education is a very important part of the cancer pathway. We know that probably the single largest difficulty in getting effective cancer treatment is late presentation by patients. And there is more that we have to do to try and persuade people on two scores. First, the whole prevention agenda. So we know that lots of cancers need never have happened. So everything we do in smoking cessation and so on is part of that patient education effort. In the diagnosis sphere, we have put both capital and revenue into the system in order to bring down diagnostic rates. Members will be aware that the Finance Minister yesterday made a statement in which £18 million additional capital is being made available for health services this year, and that includes £2.5 million extra capital for diagnosis on top of the extra capital that had been made available through the health budget. The capital money is one-off, the revenue money is for recurring services. I expect to have the detailed plans from all the health boards within the next couple of weeks that will show me how that extra money is to be deployed. I am looking to them to provide plans that give me confidence that with the extra money they've got and with the extra capital that will allow them to invest in services, we will see a real and rapid diminution in the number of people who are waiting more than 8 weeks. Within the next few weeks, we will issue fresh guidance to all health boards, giving a clearer definition of what the role of a key worker should be, who should be identified as one. Our ambition is that every cancer patient in Wales has a key worker, knows who their key worker is, that the key worker takes an interest in clinical and non-clinical aspects of that patient's care.